Hi, everyone. Welcome back to the Breast Cancer Podcast. Hello, I'm your host, Dr. Deepa Halaharvi, a fellowship trained breast surgeon, and also happen to be a breast cancer survivor, thriver, and a warrior, living my best life. As you know, breast cancer affects millions worldwide, touching lives in a profound ways. Whether you're someone facing a diagnosis or a supporter seeking information or just eager to learn more, this podcast aims to be a beacon of understanding, hope, and empowerment. I'm here to talk about all things breast cancer, from surgery to survivorship, as well as high risk for breast cancer to metastatic breast cancer. My goal is to provide you with reliable information, share inspiring narratives, and foster a supportive community. I know firsthand the challenges breast cancer diagnosis brings. Throughout this podcast, I will give you strategies to handle difficulties that arise from cancer diagnosis. We'll have insightful conversations with medical experts, researchers, survivors, caregivers, and advocates. I will tackle topics that impact our lives as cancer survivors. My goal is to educate you and empower you to live your best life. I definitely have. Well, let's get started. Hello, everyone. Welcome back to the Breast Cancer Podcast. I'm Dr. Deepa Halaharvi, breast cancer surgeon, survivor, and your host. And I'm very, very excited today to have Dr. Kavya Krishna. She is a wonderful medical oncologist here in Columbus, Ohio, but she is going to help you with the knowledge of breast cancer in young women. And this is not just going to be in Columbus, Ohio. This is right now in 144 countries. So I am incredibly happy, and thank you so much for taking the time. You
It's
have
my
a busy
pleasure.
you have a busy schedule, I know, and you're
Thank
seeing
you.
patients in the
Yeah.
clinic, in the hospital. So I really appreciate it,
Yeah.
and viewers appreciate you as well.
Thank
So
you.
thank you so much for being here today. So we're going to be talking about something that feels very heavy. Unfair is the word I would use to say it is breast cancer in young women. And when breast cancer happens in young women, I know you see a lot of them. It not just interrupts their life, but it interrupts their plans for future. It interrupts their identity. It interrupts their even maybe ability to have kids in the near future. And so, in this episode, I really want to bring some knowledge and some tools to empower yourself so you can advocate for yourself. So, whether you're a young woman watching this or you have a young woman as your daughter or daughter in law or wife, this is a very valuable information and you don't want to miss it. So, let's start. There's something especially unsettling to hear the words you have breast cancer, especially if you're in your 20s, 30s. That's not supposed to be part of the plan for your life. You're supposed to be building your life. You're supposed to be building your career. You're supposed to be building your future. And you're supposed to be building your family. But yet, far more young women are getting diagnosed with breast cancer. So today, I want to answer some of the biggest questions, and now have Dr. Kavya Krishna, who is an expert and who takes care of young women. And so we will not just talk about the facts, but we'll talk about what you can do to advocate for yourself. And that's the whole reason this podcast is there. So you advocate for yourself and empower yourself and help others with the knowledge that you gained on this podcast. So, Dr. Krishna, let's get started, shall we?
Yeah.
Why are we seeing more breast cancer in young women?
I think that's a very important question. And I don't think we have all the answers, but there are many factors that do point towards certain increased risks. So to name a few, of course, this is not all inclusive, but if the woman has a family history of breast cancer or certain other types of cancers like ovarian cancer, pancreatic cancer, sometimes the genetic factors can
Right.
play a role. So that is a big one, but that is actually not the most common reason why younger women get cancer. There are some other additional risk factors that we are seeing as the times are changing.
Yeah.
Women are having kids at a later stage and later age, and sometimes that does increase the risk for getting
Right.
breast
Right.
cancer. Getting their periods at a younger age
Right.
or having kind of a long menstrual life can also increase the risk of getting breast cancer. In addition, there are a lot of environmental factors,
Right.
that we know about, where we know there is a clear association, and there are some that are still gray, and we are still learning about it. So some of the big things would be, if with the increasing rates of obesity that we see, we do
Yeah.
see that there's increase in a risk of many different types of cancers, but especially breast cancer and colorectal
Yeah.
cancer.
Yeah.
So that's a big one. And some other lifestyle factors like sedentary lifestyle or excessive use of alcohol, smoking, these can also increase the risk of getting breast cancer. But more often than not,
Yeah.
women can still get breast cancer when they do not have any of these risk factors. It can be sporadic, it can happen in
Yeah.
anybody, and it's not because of something they did or not something that they did not do.
Right, right. And oftentimes, I think sometimes we feel guilty and we start thinking, what did I do to get the cancer?
Yeah.
And you're saying most of the time, I mean, they did not do anything to get cancer. It just so happens.
Yes.
I have also seen women who work out, are in good shape and exercising and taking care of themselves. So it's really hard to predict. And I
Yes.
often hear, I don't have family history of breast cancer. Do you hear that often in your
Yes,
clinic? Yeah.
yeah. Especially when a young woman is diagnosed with breast cancer, they are going through this phase where they're shocked
Yeah.
that they were diagnosed with breast cancer. And a lot of patients that we see, they are very healthy at baseline. They have excellent, lifestyle factors. They have no family history, and here they are,
Yeah.
diagnosed with breast
Yeah.
cancer.
One thing I do notice in those patients who come in with they're working out, taking care of
Mhm.
themselves, they get diagnosed. And I want to know if you see the same thing. I see that they're very resilient as they're going through the
Mhm.
treatment, whether it's surgery or chemo and radiation. So I do say like keep working out, keep taking care of yourself because
Absolutely.
that's going to help you through the treatment. Would you agree with
Yes,
that? Yeah.
absolutely. I
Yeah.
think movement and staying active,
Yeah.
working out as much as they can, but
Yeah.
listening to their body becomes a very important part of their treatment plan.
Yeah.
And
Yeah.
also good nutrition, taking care of themselves, getting
Yeah.
enough rest, all of that.
Yeah. Yeah. That's all good information to know. And so you did not cause this, is what you're
Mhm.
saying, that you
Yes.
did not cause it. So first, don't blame yourself. Unfortunately, if you're diagnosed and you're here, the next thing to know is what can I do next? And hopefully today's show, we will, give you some of those
Mhm.
answers. So what does a young breast cancer actually mean?
So typically, when we look at terminologies and how we define cancer in the young, usually when we are talking about breast cancer in the young, it's typically diagnosed in women who are younger than 40 years old. But sometimes we can even consider women who are premenopausal, younger in their 40s, also potentially to be in this category. But we are seeing a rise of breast cancer happening in women younger than 40.
Yeah, yeah. Just today, I diagnosed a 35-year-old, unfortunately. Yeah, and I have plenty of women between under 50, I would say,
Yeah.
and quite a few women under 40, unfortunately. And I know, and you said premenopausal, and that
Hmm.
could be considered as a young breast cancer
Yeah.
diagnosis.
Mhm.
So, who is at higher risk for breast cancer at a younger age? I know you said it could happen to anyone, it's
Mhm.
sporadic, you don't have to have family history, but is there any factors that could certainly increase the risk of breast cancer?
Yeah, absolutely. So there are some very well-established factors that
Yeah,
we know can increase the risk for getting breast cancer. One is if they have an underlying genetic
yeah,
mutation. Some of the common mutations that we hear about are BRCA1,
right.
2, or the BRCA1 and 2. Then we also know about PALB2, CHEK2. That's just skimming the surface. There
Right.
are many, many different types of genetic mutations that can be
Yeah.
associated with increased risk of getting breast cancer. Also, women who have had prior cancer, a different type of cancer, and they received radiation therapy to
Right.
the chest.
Right.
After several decades, they can get late toxicity with increased risk of getting breast cancer.
Right.
So that is definitely an important factor to
Yeah.
take note of
Right.
because in patients who were diagnosed with pediatric cancers or in their
Yeah.
teens and they were treated at a young age, we have to focus on high risk screening and
Right.
surveillance for
Right.
those
So
patients.
they should be seeing their doctors on a regular basis to
Yes.
get high risk MRI and
Yeah.
mammograms. Yeah.
Yeah.
Yes.
Yeah.
So I think, when you're talking about these genetic mutations, I think one of the things that comes to my mind is how many of us really know what happened in our family, right? Did our
Hmm.
family members have certain type of
Yeah.
cancer? Is there anything we should be doing for that, right? Like we should be probably be open and be talking about it amongst our family members.
Absolutely. Yeah. I think that open communication and just kind of being aware, at least among our close family
Right,
members, about the health history
right.
is definitely helpful.
Right,
Mhm.
right. And also, it's all about educating yourself, empowering yourself so you can help your kids, your offspring. So, I do think, I talk about this a lot on the podcast is how it's important to talk to your family members about the family history because, like the mutations Dr. Krishna mentioned, sometimes you don't know that even you have those mutations in your family or yourself if you're not talking about family history. So,
Absolutely.
um, should all young women with breast cancer get genetic testing? Would you say then?
Yeah, that's a very good question. And the answer is yes. And per guidelines, if a woman is diagnosed with any type of breast cancer, there are different types of breast cancers, but any type of breast cancer, if the um, woman is less than 50 years old, we do recommend genetic testing, even if they do not have family history of breast cancer or any other cancers.
Okay.
And it has very important implications why that is recommended.
Okay.
And we can go into that I know that one of the things it does influence are the surgical decisions.
Right.
So I don't know if Dr. Halarvi, you want to
Yeah,
weigh in on
yeah,
that?
yeah. No, actually, that's a good point. So you had mentioned BRCA mutation
Mhm.
and some other mutations. So for a woman who's diagnosed with a BRCA mutation, in addition to having cancer, the risk of cancer coming back is a little bit higher, especially in a setting of breast conservation.
Mhm.
And they also have a higher prediction of getting cancer on the opposite side. So sometimes it does weigh in your decision of what type of surgery you want to
Mhm.
have. So you're exactly correct. And we usually get our genetics as soon as someone who qualifies for genetic
Mhm.
testing. Anymore from our organizations, which is American Society of Breast Surgeons, they recommend almost everyone to get genetic testing. They
Mhm.
think everyone should be getting tested. We just have not been testing enough people to know how many mutations are out there. But I do agree, a young woman, especially under age 50,
Mhm.
with our family history, does qualify for genetic testing.
Yeah.
And yeah, so.
Yeah, and I will add that it's also important as a medical oncologist for me to counsel and guide some of the treatment decisions for our
Oh, yeah, that's
patients.
correct. Yeah.
So, if there are specific mutations, just to give you one specific example, if a patient has underlying BRCA mutation, it could influence some of the treatments that we could give
Yeah.
them, what we
Yeah.
call systemic therapy.
Yeah.
They may be more sensitive to certain types of chemotherapy agents, or they may be a candidate for targeted therapy if they qualify and if they meet all the criteria. So, genetic testing not only has implications for surgical decision making,
Yeah.
but also for some of the medical decision
Yeah, that is
making.
correct. That is correct. I have seen PARP inhibitors that you give for two
Yes,
patients who are BRCA positive patients. So,
absolutely. And I want to add that with the genetic testing, it informs decisions about the future. So,
yeah.
you know, if somebody has BRCA mutation, it can also increase their risk for other cancers. And once we are past the treatment for breast cancer, patients would need additional screening for other
Right.
types of
Yeah.
cancers. And it may have implications for their family members to be tested,
Right.
siblings, children.
Yeah.
So it has a wide reach,
Yeah.
and it's very important to talk about genetic
Yeah.
testing and be aware why we recommend it.
Yeah, that is a great point that you make. And, patients ask me, why do I need to get genetic
Mhm.
testing? I don't want to know, but you are
Mhm.
exactly making a great point. Not only that has implications for you, whether it's treatment through surgery or systemic therapies, it can have implications for your family members. But not only that, we're not just talking about breast, it could have pancreatic cancer, prostate cancer,
Yes.
melanoma, and for men, BRCA2 typically is associated with breast cancer. Men can get breast cancer.
Yes.
So, the one other point I did want to say is not all your family may not have family history of breast
Mhm.
cancer, and you may still carry a mutation. So,
Yes.
and that's why we test, young women when they get, or men, any men of man of any age, for genetics. So.
Yeah.
So, in terms of what symptoms a woman should never ignore, um, so typically, it same thing that I would say for women, whether whatever age, it doesn't matter.
Hmm.
So a palpable mass, a mass that you feel on your breast, whether typically these masses are hard and they don't move around as well
Hmm.
as those benign fibroadenomas. They move around.
Hmm.
Nipple changes, nipple discharge, skin changes, dimpling, pulling in on the skin, lumps underneath the armpit, enlarged lymph nodes. And sometimes you may have lumps that come and go with your menstrual cycle. Those are not as worrisome as masses that are going to stay if it's
Hmm.
cancer. So that's what you really need to pay attention to your body. And I usually say check yourself a week after your periods when your breasts are easier
Yeah,
to
that's a very
examine.
good
Yeah,
point.
yeah.
And Dr. Halaharvi, do you think that when younger women are diagnosed, do you see a tendency towards diagnosing these women at a later stage? Do they present at a more advanced stage?
I think, they could. And the reason is this, a couple of things. One is they're not thinking about cancer.
Hmm.
So whatever the mass they feel, they may think it's benign. One other point I do want to say is breast pain, even though we say breast pain is not strongly linked to breast
Hmm.
cancer, I've seen women who present with breast pain in less than 5% of the time it is diagnosed, you can have cancer associated with breast pain. And in terms of women are not thinking about cancer, just like men, they're not thinking about cancer.
Hmm.
Sometimes they do tend to get diagnosed a little later stage. Women have dense breast tissue,
Hmm.
so sometimes it's difficult to distinguish a cancer from, dense breast tissue. The other point is they don't have any screening guidelines.
Hmm.
In the United States, our recommendations are starting at age 40, and there's no
Correct.
guidelines for under age 40. So
Correct.
unless if you know your family history, there's a family member who's diagnosed with breast cancer, say at age 40, you can start getting your mammograms at age 30. So it's 10 years younger than your family member. That's another reason that you would want to know your family history. But I do think they do get diagnosed a little bit later stage, but also a little bit aggressive type of cancers
Hmm.
as well. Would you agree? Do you see
I
that?
agree,
Yeah.
and I think that is a very good point that you raise, um, because we always look at how long it takes for the cancer to grow
Right.
and cancer to progress, get bigger, spread to the lymph nodes. And when we see younger women diagnosed with breast cancer, not all the time, but a lot of the times we see that they have more aggressive biology.
Yeah.
So that may be another reason why
Right.
they may
Right.
present with
Right.
more
What
advanced.
hormone receptor status do you typically see in young women?
So when we talk about breast cancer
Yeah.
subtypes, we are always looking at the receptors.
Hmm.
There are three receptors that we look at: estrogen and progesterone receptors, which are the hormone receptors, and the HER2 or the HER2 receptor. So when all three are negative, we call it triple negative breast cancer. And if it is HER2 positive, we call it HER2 positive breast cancer. If we look at statistically speaking, all patients, the HER2 positive and triple negative breast cancers are usually the least common. But when we look at younger patients and if we
Hmm.
look at the distribution of the different types of cancers, we see that younger women tend to have a higher percentage of having either triple negative breast cancer, where all three receptors are negative, or
Yeah.
HER2 or HER2 positive breast cancers. And those tend to be faster
Yeah.
growing and, they can get bigger over a shorter period of time, also travel to the lymph nodes and other areas.
Yeah.
We do see patients who may have hormone receptor positive breast
Yeah.
cancer as well, but the proportion can be different when we compare with all patients versus the younger women.
Yeah, yeah. Also, with this hormone receptors such as triple negative and HER2 positive, do they have good response to chemotherapy?
Yeah, and that's a very good kind of segue to the treatment
Yes, yeah,
discussion. Yes, so when we start talking about treatment recommendations for breast cancer patients, we make the treatment recommendations based on the type of breast cancer. So when the breast cancer is triple negative or HER2 positive, almost always chemotherapy is a part of the treatment
yes,
plan. And the reason for that is they also respond very well to the specific treatment regimen.
yeah. Okay.
And it also includes other drugs, not just chemotherapy. So, what I mean by that is in triple negative breast cancer, we also use immunotherapy in combination with
Yeah,
chemotherapy.
yeah,
In the HER2 positive breast cancer, we use HER2 targeted therapy
yeah,
in combination with chemotherapy.
yeah,
And we can see fantastic responses in these patients
yeah.
when they receive the specific treatment regimen for them.
Yeah, yeah. That's a really good explanation. While it may be aggressive type of cancer, but also we have treatment options. And especially
Yes.
we are doing, that research is so advanced in the breast cancer world. Like, we go to all these conferences
Mhm.
together. We've
Yeah.
gone to several of them together, and there's newer drugs that come out for each of these different
Mhm.
subtypes of hormone receptor status. So there is so much hope in what you guys are able to do now. And I always call you guys my superheroes. All I do is remove the cancer, but you're actually treating the patient. So I'm so grateful along with our patients. And I think what we are saying is for patients to advocate for themselves. You're never too young to get breast cancer. If you hear that, it's false. And you're never too young to get. My youngest patient is 19, and I don't want to scare anyone, but it can happen in young women. And so advocating for yourself, and if you're being dismissed, maybe seeing another provider or doctor, I think it's important. So
Absolutely. And there are also some unique concerns or challenges that our
yeah,
younger patients face.
yeah,
Um, so they are kind of in this unique phase of life where they may have young children
yeah,
or they have not yet started their family or completed their family. And we are talking about all of these treatment
yeah,
recommendations, which can affect their fertility.
yeah,
So, addressing that
yeah,
before we walk down the path of their treatment plan is very important.
yeah,
Because once we start the treatment, then the infertility rates can go up.
right.
So, addressing some of the unique challenges that come up in younger women is very important.
Yeah,
So, I know you briefly mentioned about
yes,
some of the hormonal therapies or hormone blockers. So, in addition to talking about chemotherapy and the HER2 targeted therapy, when we see women who have hormone receptor positive breast cancer, we also start talking about anti-estrogen therapy
mhm,
or the hormone blocking therapy, which brings with it its whole kind of bag of side effects, and we have to help women navigate that. And it also affects their fertility, it affects their bone health, it affects a lot of other things like their cardiovascular health
right.
because they are being exposed to kind of the menopausal side of things or the
Yeah,
hormone blocking effects of things much earlier
yeah,
than they would have experienced
yeah,
if they were not diagnosed with breast
yeah,
cancer.
yeah.
So there's a lot of different and unique challenges that we have to keep in mind when we are talking about the treatment algorithms for our younger patients.
Yeah, yeah. You make a really good point. Someone we say average age for menopause is 51. And not, I mean, I'm past 51, but I'm still haven't gone through menopause. I think even the people who go through natural menopause, I think it takes like what over a period of 10 years, right? To
Yes,
in order to go through menopause. And
absolutely.
here we are, performing surgical menopause, medical menopause,
Mhm.
because that's the part of the treatment regimen for these women. And I often feel very guilty for putting these women through it. It's a very necessary medication that they need to take, but it causes a havoc on their system, whether it's cardiovascular, their bone health, their mental health.
Yes.
Is there anything that they can do that is, if you were to say one thing, this is
Mhm.
one thing that's like a very well proven,
Mhm.
you know, drug slash something that they can do, what would you say that is?
Absolutely.
Yes.
Yeah, when we are talking about the all the deleterious effects of anti-estrogen therapy and all the other, after effects of some of the other systemic therapies that they receive, the one thing which has been proven with
Yeah.
evidence to help women navigate some of those
Yeah.
symptoms and minimize some of the symptoms, maybe not completely take it away,
Yeah.
is regular exercise.
Yeah.
It is a huge part of your
Yeah.
treatment plan. I know
Yeah.
we talk about the drugs that we
Right.
administer, but it's been proven that regular exercise actually reduces the risk of breast cancer recurrence and improves overall survival.
Yeah. And we usually say taking anti-estrogen is like decrease the risk of cancer coming back by
Mhm.
50%. Do you have a number for women who exercise?
I think that's a little difficult to quantify.
Yeah.
We have a lot of retrospective studies
Yeah.
looking at it or smaller studies looking
Yeah.
at it, but I would say it's probably going to be in the range of 25 to
Yeah. That's
30%, which
what.
is a huge
That's
number.
huge number. I
Hmm.
mean, to like, you take tamoxifen, which I've taken that for several years, obviously I had some side effects, but really one thing that really consistently helped me was when I was exercising.
Hmm.
And for me, and I don't know, correct me if this is wrong, I strength training was my thing. Like
Oh,
that helped me the most mentally. The aerobic, that kind of stuff helps me temporarily, but I think the strength training carried my mental health, I would say 24 to 48 hours. And that's why I'm very good about going to
yeah.
that because when I don't go to
That's very inspiring.
yeah, when
So,
I don't exercise, especially do strength training, I can see effects on my mental health. And so, if there is something that we can do for ourselves, unfortunately, we didn't ask for cancer; it happens to us. But it's like control the controllables, right? So, one thing we can do to control ourselves is exercising, and we have to make time for exercise. And do you have a specific exercise that's your favorite?
so I love strength training as well.
Yeah,
And I think, strength training at least 2 to 3 times a week
yeah,
is recommended. If you can do a little more than that
yeah,
with supervision, that's great.
yeah,
But it's also important to incorporate just being more active, the activity, walking when you can. And there is some credibility to the steps, the
right,
steps
right,
that we
right,
track. So
yeah,
being
yeah,
active every day,
yeah,
movement, just
yeah.
moving as much as we can
Yeah,
is extremely helpful. And another reason or another plug for strength training is we talk about bone health, the
yeah,
negative effects of bone
yeah,
health with all the treatments that we
yeah,
recommend. And strength training is proven to
yeah,
improve the bone health.
yeah,
So,
yeah,
and some of the challenges that women face as, we get older, or even when we block the
yeah,
estrogen receptors,
yeah,
which, it's much more dramatic effects in younger women.
yeah,
They can notice that they're gaining weight. And,
yeah,
I have a lot of patients tell me, I have all this weight in my
yeah,
midsection,
yeah,
and I'm doing everything that I
right,
can. And,
right,
it's
yeah,
just not going away. And this is where strength training, building some muscle
yeah,
mass really helps
helps, yeah,
in making that a plateau or minimizing the
yeah,
risk of having significant weight gain.
yeah. Um, I just thought of a question. What are your thoughts on GLP-1 medications in breast cancer patients? Because I get asked that question quite a
Yeah,
bit.
that's become a very important question, and I think GLP-1 drugs are ubiquitous now.
Right,
They're everywhere,
right,
and they have a lot of indications. So my perspective on this is that if a patient needs to go on GLP-1 drugs because of metabolic syndrome,
right,
they have
right.
diabetes.
Yeah,
I think that's very, very reasonable.
right, right,
But if we are looking at GLP-1 drugs for weight loss alone, I always encourage patients to maximize the other intervention
right, right.
because with the GLP-1 drugs, they work very well. They're generally well tolerated, but they do come with side effects.
Yeah,
And they do come with, the challenge of having to be on them longer term. So it's about weighing the risk versus benefit. In terms of safety signals, is there any contraindication for
yeah,
women to take the GLP-1 drugs? When they are undergoing treatment for breast cancer, or if they have a history of breast cancer, there really hasn't proven to be any kind of safety signals. We got to follow this data long term, though,
right. Yeah, that's the key.
because the data keeps evolving.
Yeah.
But so far, when we see, we have not really come across any major safety signals.
That's good to know. That's good to know. And there is space for people to use this in setting of like metabolic syndrome, diabetes, because,
Absolutely.
and I always say this too on podcast is the most common cause of death for us women is not cancer, it's heart disease. And so
Mhm.
you still want to protect yourself from heart disease, which means you'll take care of your weight, your diabetes,
Mhm.
other things that go with it that can lead to heart disease down the road.
Absolutely. Yeah. And I know we talked about some of the treatment challenges and how treatments can be a little bit different in younger
Yeah.
women.
Yeah.
And big part of their treatment also is the type of surgery that they're going to need.
Yeah,
So,
yeah.
Dr. Halaharvi, can you
Yeah,
kind of
yeah.
talk about whether the surgical approach is different in younger women or
Yeah.
what their options are?
Yeah. So actually in March, if you haven't heard my podcast in March, it was about history of breast cancer
Mhm.
surgery, which is, I find it very interesting. And because I think you need to go look at the history, what's been done, centuries ago, and now what we're doing now. So back in the Egyptian era, women just were getting their chest mutilated, essentially. They would have radical mastectomies and, removing the lymph nodes, the pectoralis muscle. This was actually as recent as 1870s. That went on for about 100 years. In 1970, Dr. Fisher and his colleagues questioned that and said, is there any survival benefit for this big surgery? It was believed that the cancer was spread, from center outward. So they would remove everything that was attached to the breast, the muscle, the lymph nodes. So that caused huge morbidity, disfigurement. Women were embarrassed. I mean, and imagine the body image and things like that. And it wasn't discussed as openly as we discuss right now. But in 1970s, Dr. Fisher, there is NACBP04, which compared radical mastectomies to modified radical mastectomy, where we were not removing the muscle. And then NACBP06, which compared mastectomy to breast conservation or lumpectomy. So there may not be as many young women in the trial, but we have enough studies to show that it is safe for young women to have lumpectomy with radiation or breast conservation, and the survival is the same. And women think like sometimes, oh my gosh, I don't have to
Mhm.
have a mastectomy. You don't,
Mhm.
and I do see it. Sometimes women do want a double mastectomy, and that's their preference.
Mhm.
But I always make sure to let them know there is no survival benefit, and um, anytime you operate and do surgeries, it changes your body image. So I
Yeah.
talk a lot about the body image for those women. So,
Absolutely. Yeah. And I really enjoyed your podcast. It was
oh, did you
fascinating.
listen to it?
Yeah.
Oh,
Yeah.
thank you.
Yeah. It was fascinating
Yeah,
to know the,
yeah,
way history has
yeah,
evolved and where
yeah.
we are right now.
Yeah, I'm like a history nerd, so
I-
I enjoyed making it. I learned so much. Every time I do this podcast, I'm always learning,
Yeah. Yeah.
So and we are, teaching others, but we are also learning. So it's a win-win situation for the both of
Absolutely.
us. So
Yeah. Yeah.
so let's talk a little bit about how these people get diagnosed. So
Yeah.
most of the time, these young women, they come to me, or I think most of the time, either to me or they go to their family doctors complaining of a breast mass. So typically, they get an ultrasound if they're younger than 30,
Mhm.
and if they're older than 30, ultrasound and a mammogram. And once they get diagnosed, most of the time they do get an MRI because they have dense breast tissue. It's hard to see. It's hard to see calcifications on an ultrasound. So a mammogram, and in addition to that, an MRI, and then they get a tissue biopsy. That's the only way to diagnose someone, is to do a biopsy. And then that allows us to know not just whether they have cancer, but type of cancer and hormone receptors. And that's when our medical oncology colleagues like yourself come into play, whether they need any type of systemic therapy before surgery. So that is like gold standard now. Sometimes women will say, just take me to surgery to remove the mass. It's not the right thing to do because you're not getting the accurate information. You could potentially be removing a lot of breast tissue that is not necessary to
Mhm.
remove. And the guidelines recommend a needle biopsy first, and it does not cause spread of cancer as, some people may think that it could.
So, when we do get a diagnosis of cancer, and as you alluded to it, the type of breast cancer is important when we do the needle
Yeah,
biopsy and we look at the stage of the cancer, like what is the size of the tumor and what is the lymph node status,
yeah,
and depending on the type of cancer, if it is triple negative or HER2 positive breast cancer, if it is a larger tumor or if the lymph nodes are positive, we generally favor doing systemic therapy, which is either chemotherapy, immunotherapy,
yeah.
or chemotherapy with HER2 targeted therapy first. And that helps us
Yeah,
understand about the responsiveness of the cancer to the
right.
treatments we are giving. So, what kind of a response that they have helps us decide the best treatment
Yeah,
plan for patients afterwards to really minimize their risk of
right,
recurrence.
right,
And as you mentioned, breast conserving surgery or smaller surgeries could potentially become an option even for patients with larger
right,
tumors
right,
if they get really good response.
right.
if originally, if they needed to have
Right.
mastectomy, they may become
Yeah.
candidates for
Yeah.
lumpectomy. So, knowing the type of cancer
Yeah.
and kind of having that multidisciplinary
Yeah.
discussion
Yeah.
with our surgery colleagues,
Yeah.
medical oncologists, the
Yeah.
radiologists, and pathologists becomes very important
Yeah.
in customizing
Yeah.
and coming up with a very tailored plan for each
Yeah,
patient.
yeah. I do want to make a point here. Dr. Krishna and I are on a tumor board conference once a week. I attend two different tumor board conferences, two different hospitals. I cannot emphasize the importance of a multidisciplinary tumor board conference where there is surgeons, there's medical oncologists, there is radiologists, radiation oncologists, there is genetic counselors, there is other, therapists and other doctors and other, nurses, nurse navigators. It's really important because we present this patient and we are always trying to formulate a plan that's a personalized to that person based on their age, the type of cancer they have, the hormone receptors. It's never one size fits all, right? And
Correct.
that's what I will say, that you also want to go to a place where there is multidisciplinary conference where your doctors are communicating with you and they are providing you evidence-based, guidelines. There's a lot of talk of alternative medicine and things like that. While I do support that along in conjunction with the recommended treatment, you just don't want to just lean on the alternative medicine because they don't have the multidisciplinary conference. They haven't had trials where women have put themselves in the trials. And so part of the reason I love the history of breast cancer is so many thousands and thousands of women have enrolled in these trials, so they sacrifice themselves so women like myself can have better life and and
Mhm.
need lesser surgeries, lesser treatments. Like if I was diagnosed 20 years ago, I would have been getting chemotherapy, but I was able to use a genomic assay which helped me in not getting chemotherapy,
Mhm.
which is it's great. But I'm so grateful for those women who put themselves in this trial. So the clinical plug in for clinical trials, I think it's important. Plug in for multidisciplinary conference and plug in for making sure you are going to those centers where your doctors are participating in the multidisciplinary conference.
Absolutely. Yeah. We got to keep advancing the science.
Yes, yes. And it's I get so inspired by Dr. Krishna and her colleagues. They're constantly attending the conference, constantly learning, and we're teaching each other, we are growing, and it allows us to, take good care of our
So
patients.
are
So
you.
so
Yeah.
yeah, thank you. One thing that's my passion that, I actually made a whole podcast on is body image,
Mhm.
right? So, I was diagnosed at 41 and I had issues with body image. 85% of Americans, I'm sure worldwide, but I just know the data for the American women, we have problems with body image. And as a young woman who's diagnosed with breast cancer, you have scars. You look different. You don't have hair. We are taking out your ovaries. We are making you postmenopausal in your 30s and 40s. You don't feel good in your own skin. And body image and hair loss, all those things impact you, not just physically, but emotional scars. I think it takes time. Your body, your mind, your brain. I always say your brain has taken pictures of your body for all those years, and now it doesn't recognize your body when you look in the mirror. You have scars. I have a lot of scars on my chest, things like that. It takes time for you to kind of fall in love with yourself again. On this podcast and social media, I talk a lot about self-care and loving yourself. That is really the only time we can like take care of our family members, because as women we are so in tune to helping others, taking care of
Mhm.
our kids and our spouses and others, but not really taking care of ourselves. But the whole body image thing, it goes back to really focusing, getting that love back to yourself, focusing on yourself, taking time, journaling, seeing a therapist. It all takes time, but it does get better. You can live a better life after being diagnosed with cancer. I know I'm a living proof for that. So,
Yeah. And I thank you for addressing that because sometimes these conversations are hard for
yeah,
women.
right.
The part about body image, it's sometimes very difficult to articulate. People feel it
Yes,
and
yeah,
they experience it, and sometimes it's difficult to share.
yeah,
So people like you who
yeah,
are vocal about it and
yeah,
advocate
yeah,
for just the wellness
yeah,
that this is normal, what
yeah,
women are feeling. I
yeah.
think that's very, very important.
Yeah, yeah. I think we just need to normalize these things, right? We
Yes.
need to say it's okay to have scars. That's not the end of the world. I still have my life and my health, and I'm more empowered now in how to take care of myself. I truly do take care of myself better since after my cancer diagnosis, but before I was taking care of my parents, taking care of my kids, going to medical school, residency, you're not just taking care of yourself. So I will say, and then I realized like if I'm taking care of myself and living a good life, I should tell this to other people. And
Absolutely.
so that's my whole reason for why I'm here on this podcast. So, Dr. Krishna, what does survivorship look like after treatment ends for these young women?
So it's a journey. It's
Yeah,
not
yeah,
okay, you're done with
yeah,
treatment and that's it, you're fine,
yeah.
you move
Yeah, it's
on
not
with
like
your
it's
life.
a switch
It's
you
not a
can turn
switch.
on or turn off. Yeah,
Absolutely.
exactly.
So survivorship, I look at different aspects, or when I think about it, or
Yeah,
when I think about my patients going through
yeah,
this, I think about their immediate recovery, right?
yeah,
After they've been through some of the harsher
yeah,
treatments like chemotherapy. How are they recovering? How are they getting stronger?
yeah,
How are they getting back to close to their baseline? So, self-care is very important during that time. And then we have patients who are going to be on anti-estrogen therapy for
yeah,
years. Sometimes it's 5 years,
yeah,
sometimes it's 10 years. Usually, we are not, in patients who have non-metastatic disease, we do not have them on anti-estrogen therapy beyond the 10-year mark.
yeah.
But 5 or 10 years is a long time. So
Right,
for for women, just to kind of recognize and give themselves grace,
great.
they
Yeah,
are dealing with some of the side effects with the
yeah,
anti-estrogen therapy. It could be hot flashes, it could
yeah,
be fatigue, it could be
yeah,
just mental fogginess.
yeah,
Patients tell me that all the time.
yeah,
I don't remember things.
yeah,
I was doing something and I forgot. So just giving yourself grace during that period
yeah,
is very important. And and then we start talking about your wellness. I always tell patients, focus on your wellness.
yeah,
Focus on building that muscle, maintaining your bone health. So exercising regularly, going for your visits, going for your mammograms
yeah.
and any other imaging that you need.
Right.
That is a part of survivorship,
Yeah,
and that is a part of taking care of yourself
yeah,
and thriving.
right.
And a big part of this also is nutrition,
Yeah,
kind of focusing on good
yeah,
nutrition
yeah,
and taking care of yourself in that regard as well becomes very important.
yeah,
We should not forget, though, that we hope and expect women to have a long life ahead of them.
yeah.
And with some of the treatments that they have gone through, they can be at a higher risk for getting cardiovascular disease
Okay.
and other associated disorders.
Yeah.
And it could be related to some of the treatment
Treatments.
toxicity
Yeah,
that they have received,
yeah,
and it could also be because we, block their estrogen receptors at an early
yeah,
stage. So making sure that women go to see their primary care physician, they're on top of things for their routine physical. They're getting screened for diabetes, and they pay attention to
yeah,
any kind of symptoms that could be indicative of cardiovascular disease.
yeah,
All of those things come into play in survivorship. So there's the acute phase where
yeah,
they're getting out of their harsher treatments, and then there's the long-term
yeah,
surviving and thriving phase where they
yeah.
need to really, take care of
Take care of
themselves.
themselves. You make such great points. I really love that you say survivorship is taking care of yourself imaging wise. So we know we just can't just think about breast cancer. There's colon cancer. The recommended guidelines now is age 45 for screening
45, yeah.
colonoscopies and any other imaging that you may need based on your medical history. And that's like a really great reminder. Also great reminder like your cancer is done, but you still have to worry about other like disease
Absolutely.
toxicities related to treatment. So what is one thing you want every woman to take from this show today?
So I think it's very important to remember that cancer just happens
Yeah,
and it is not your
yeah,
fault. And it's very common for women to feel
yeah,
guilty
yeah,
and kind of go through in their mind, what did I do? Why did
yeah,
this happen?
yeah.
But the most important takeaway is that it's not your fault.
Right. No, that's great. I frequently have women say, "What did I do to get it?" I said, "If I know the answer to this, I would be a millionaire on a beach someplace." So I don't know the answer to this. It just happens, unfortunately. It could be bad luck. I mean, who knows? But I think one thing, like, I really recommend women to take away from this show is you're allowed to be scared. You're allowed to need support. You're allowed to be angry. But know that you're not going to live in that space forever. You just go through your grieving process, the denial, anger, bargaining, depression, acceptance. I went through that. I was stuck in that phase for a whole year. So I always tell women it's okay to go through those stages of grief, but don't stay in any one stage too long. Figuring out your coping mechanisms, whether seeing a therapist, journaling, talking to your physicians, getting into a group support. There's a number of different ways. The thing is, you have to ask for help, and that is strength, and it's not weakness. And know that you're not alone. And this is just one chapter of your story. It's not your complete story. And so, and we can say this without a shadow of a doubt because we are taking care of young women. So, rapid fire questions. Are you ready?
Okay.
Okay. Young breast cancer is always genetic.
No.
Okay. Mastectomy guarantees no recurrence.
No.
You can never get pregnant after breast cancer.
Not true at all.
Yeah, that's really great. I'm glad we are talking about this because I know, several women who have had babies, a couple of years after the diagnosis, after they've been on the recommended, treatment. Life will never feel normal again. Would you say yes or no?
No.
Okay, I agree. Thank you. Yeah, it may be different, but it may be deeper, but it's not, it's good. It's going to be great. My life is great. And I hope to people who have gone through this journey that you're able to find joy again. And if you're a woman listening to this and you're walking through the breast cancer journey right now, I hope this episode reminds you of something important. You're more than a diagnosis, more than a pathology report. Hardest thing that's happened to you is this cancer. And also if you know of someone who's going through this right now, listen to this episode, share this episode. Just remind that woman that she is not alone. She has plenty of support. This information matters, compassion matters. What we bring together, it's really where the healing really starts. So I'm so grateful to you, Dr. Krishna, for being here today. I know you're such a busy woman and saving all these lives, and I really appreciate it. You're helping so many men and women around the world.
And thank you for having me on this podcast. It's been great to be here and just talk to you as a friend and a colleague and go through some of these important questions. So thank you for having me.
Thank you so much. Thank you. If you love this episode, please share it with your friends and family and give us a 5-star rating. And I hope to see you later. Bye-bye. Thank you, everyone, for tuning into the Breast Cancer Podcast. Remember, you're not alone in this fight. I encourage you to be an active part of this podcast. Please share your stories, questions, and suggestions for future topics at my website called drdeepahalaharvi.com. And please share this podcast with others, especially if you found it useful. And please also give it a 5-star rating, if you will. Stay connected as we navigate the complexities of breast cancer. Until next time, take care and keep shining brightly. Disclaimer, this podcast is not intended for complete medical advice, so please talk to your medical professionals.